Welcome to MD Newsline, Dr. Sumrall. Please introduce yourself to our audience.
Sure. So I'm Ashley Sumrall. I am a physician and I specialize in neuro-oncology, so patients with brain tumors. And then a passion of mine is patient advocacy.
So, talk to me a little bit about what disparities and trends you see in the world of neuro-oncology.
In neuro-oncology, we have unfortunately not focused much on disparities. So it's a newer area for us, looking to see how care is delivered in communities across the country. We're learning more about socioeconomic status and how that plays into patients being able to access care and get what they need.
So, in the world of neuro-oncology, what are you most excited about when it comes to the research?
Um, well, today, one of my colleagues put up a slide for one of our diseases that we treat that said, we've had 100 years of research and we have the same projected survival. And that really resonates with, we have so much to do. I'm the most excited about the work that we're doing in profiling tumors. For years, we have kind of treated all brain tumors as a group that behaves similarly. And in the last 4 to 5 years, we've learned much more about the diversity of that group. And so as we continue to build that body of work, we will be better informed so that we can take better care of our patients.
So, your focus is neuro-oncology, and I believe that includes
Yeah.
glioblastoma. Have you heard of that researcher who's documenting his journey with having glioblastoma?
The guy, he's on Twitter. I'm blanking on his name though, and he's been journaling his story. Yes. Um, so I spend much of my time caring for patients with glioblastoma. It's a heartbreaking condition. And we now know there are different subtypes of glioblastoma. There have been several really courageous patients who have journaled their different journeys online. There are several patients who are very much into advocacy, and I call them friends. One of them is presenting at this meeting, and to really sit and listen and digest their experience is just, it's heartbreaking.
Have any risk factors been identified or any trends? Obviously, this is super rare. So, obviously, no one's coming in to say, hey, doc, how can I stop myself from getting glioblastoma?
Right, right.
Yeah. So, when it comes to early identification or even prevention, is there anything in the data?
Really nothing. So for years, we've tried to figure out why does this happen to people? Glioblastoma touches all age groups, infants all the way to the elderly. And every time we think we may have an environmental factor, we can't prove it. There are a handful of conditions where gliomas in general will run with these cancer predisposition conditions. But that makes up a very small percentage. Even with years of investment, we still don't truly understand why this happens to people.
And as far as disease progression and response to treatment, are there any differences among different populations as far as the aggressiveness of the disease or how they respond to treatment? I know, for instance, with the brain, life stages impact how the brain functions and sometimes how it responds. People have different, neurobiology.
We know that individuals that are healthier and usually younger can tolerate treatment better. So sometimes our patients who are older at the time of presentation, they can't endure the treatment. One of the big tools that we have is radiation. So when you radiate a brain, the age and the function of that brain matters. So if we treat a child with brain radiation, we impact them for the rest of their life, affects their growth, their development. But also, if we take an elderly person and radiate them, they are going to be more prone to memory changes. So a big part of meeting a patient with a new diagnosis is discussing what we can do and then what we should do. And I always want patients and their families and caregivers to be well informed. If you have a patient who goes through a treatment and then when they reflect, they say, I wish I hadn't done that, then we haven't done our job. So we all take it very seriously that we inform them as much as we can before they head down that road.
Let's talk about technology for a second. We've had different changes and advancements in technology. For example, we have AI being used to accurately analyze mammograms. We've got gene editing for sickle cell. So I'm wondering if there's anything that you've seen emerge in neurobiology and glioblastoma that you think is promising.
Ugh, I'm so hopeful that AI advances how we care for patients. I can tell you that ASCO, as an organization, and the board of directors for ASCO, they've invested a lot of effort into learning about how AI can be used to improve delivery of care. Um, in the field of neuro-oncology, where we're really seeing AI is through neuroradiology. So at our institution, there is an AI directed program that helps MRIs run faster. So, a real time benefit is when the patients are in the machine, that time has been cut down by about 40%. And no patients enjoy being in a scanner, especially if you're talking about our patients with spinal cord tumors. So, the patient experience has been improved by that technology. The other thing that happens is that version of technology also influences what we call perfusion imaging. And we're increasingly using that to look at blood supply in the brain and also to help us delineate if you have active tumor or if it's damage from surgery or radiation. So we're already using those tools. I really look forward to using AI to analyze data and hopefully help us predict who will our long-term survivors be? Why are some patients prone to do better, live longer? Um, we're all really excited about it, but at the same time, we don't fully understand the world of AI. So we've got to catch up and learn, how to use that.
I'm thinking about data right now, and especially thinking about where some of the blind spots are in the data, uh, specifically related to clinical trials. What are some of the areas that you hope to see improvement in the future?
So, unfortunately, this is an easy question to answer for neuro-oncology, and that is with tumor profiling. So, in my wheelhouse, we have primary brain tumors such as glioblastoma, and then we have metastatic disease, so lung cancer, breast cancer that spreads to the brain. And what we've learned through some small studies, those tumors can change with time. So, if you're sampling a primary brain tumor, we need to take that tissue and send it and look. We need to look for these mutations, fusions, alterations. And the other thing that we've learned is that a cancer below the neck, once it goes to the brain, oftentimes they have differences. And the only way to know that is to profile that tumor. I tell my patients, I say, you can't catch a fish if you don't go fishing, right? So we don't know what we don't know because we have opportunity to sample all of these tumors. And unfortunately, in the neuro-oncology field, we're behind some of our colleagues, our breast cancer, lung cancer colleagues that have been focused on biomarkers for a long time. So there's a growing enthusiasm in neuro-oncology to start sending all of these tumors out. And when we collect that data, it will be so powerful. We can work together. We can link arms across centers and pull that together. But we are behind.
Okay, so let's talk about drug shortages for a second. I know, just saying it sounds ridiculous. We talk about this from an insurance perspective a lot, and I want you to touch on that. But what's the other impact of these drug shortages?
Yeah, sure. So I think anyone who goes into medicine, you go into it with this view that you want to do everything possible to help a patient and to help a family. And for me, that's a big component of advocacy. If I talk to some of my colleagues who've been oncologists for longer than me, they'll tell you that drug shortages have been around forever. And so I've been at this for 20 years now. And over the last few years, I've sat with patients and families and had to say, we don't have access to that drug right now. And these are inexpensive drugs. We have the drugs that are $20,000 that are easily accessible, but are much cheaper drugs we don't have. And so I think the noise just reached a certain volume in the past year where people are paying attention. And a lot of our advocacy efforts when we go to Congress has been focused on this. I'm not a pediatric doctor, but some of these drugs that keep popping up under shortage, they are drugs that are used for curative intent treatment for children with cancer. And how do we say that we deliver world class care and the best cancer care when we have children in our country who can't receive appropriate care for curable intent cancer? That's unreal to me.
It really is unreal. Why are there shortages?
So it's a complicated issue. And as you dig into it, you start to learn it's difficult to predict how much chemo drug is needed. But there's been a disconnect between centers. So cancer centers have not developed a system to share or exchange medications. So through these shortages, we've actually developed these networks online where friends will reach out to each other and say, "Do you have carboplatin? I need this much. Can we negotiate? How this works?" So we've had a lot of interest from our congressional leaders this year in how to approach this. 2 weeks ago, I had a lovely conversation with one of our health policy fellows working with the Ways and Means subcommittee, and they're trying to develop solutions. And what that may look like is, how do you incentivize these companies to make the drugs in the US and not overseas? Also, can you incentivize them with tax credits or other benefits? Because these are drugs that are not necessarily going to earn these companies a lot of money because they're older. So something other than just altruism has to encourage them to make this happen.
So, are there roadblocks with public and private institutions when it comes to sharing some of these resources? What has been your experience with that?
There's red tape everywhere. So there's reimbursement, and depending on your payer, whether it's a third party payer, whether it's a federal payer, that matters. Also, there are multiple safety issues. There should be regulatory and safety concerns around chemotherapy, of course. I'm really fortunate that I work for a large hospital system. And so, among all of our different centers, we are able to ship things back and forth and work together. But it really involves having your administrators, your pharmacists, your physicians all together. It takes a big team approach.
So, how does insurance come into play with all of this? I know you mentioned pediatrics, but I'm wondering if there are any other diseases that face these types of shortages and coverage complications.
There are. So, in addition to being active with ASCO, I'm also involved with AMA. And so I hear about some of that through that participation. You may hear from some of your colleagues in infectious disease that there are drug shortages. Um, any of these medications, such as insulin, that is a classic. Perhaps it's not a shortage of supply, but patients don't have access. So, one part of it is shortage, but a bigger part of it is access. And how do we pool our efforts across specialties to help fix this?
What are some of the ways that doctors deal with this? I know it's probably on a case by case basis, maybe. Working outside of these systems, what do they do when patients are in front of them that don't have access to medication? What are some of the things that they're doing for these specific patients to kind of keep the care regimen moving forward?
It's hard. If it's an access issue due to insurance, that's one pile. If it's an access issue due to drug shortage, it's different. ASCO has developed some really incredible guidelines about, if you don't have this drug, here's your next best option. I think where it becomes the most difficult is in the exam room when you're explaining that to a patient. So if you have a patient with breast cancer and you want to give a drug and you can't, and you have to explain the alternative. I've heard countless stories from friends about those moments. And as much as I speak about this, I still find myself a bit speechless that this is where we are.
So, are there private options or outside options for patients to access these medications in other ways?
Not that I'm aware of. Now, if it is if it's a payer issue, there are patient assistance programs. There are charity organizations that help. But if it's truly, you know, it's like if you go to the store during the pandemic to buy toilet paper and there's no toilet paper. And there's no way to buy it online, and there's no way to get it anywhere else. So it's just very sad.
Wow. So, outside of advocacy in the hospital system or health system, what are some of the other ways that people can help address these kinds of access and shortage issues? What should people do who want to participate?
So there are a couple of ways you can look at it. There's federal, state, and grassroots. And I encourage my patients to become involved. I may be annoying. It may be annoying, but I like to ask them if they know who their leaders are. Do you know who represents you? Do you know how to reach out to them? Because invariably issues will come up and we can reach out for help, whether it's an insurance commissioner or an elected official. And we use those tools. So it can be as simple as sending letters, sending emails. Um, we used to say call them, but so many people don't like to talk on the phone. And it's so easy to send a quick text or email. So the offices tally those responses that they get, and they use that to form how they will vote for certain things. And so there are multiple areas. ASCO, for example, has a wonderful advocacy site where you can go in, take a template email, adjust it, add your own story. So I encourage people to not be afraid to do that. You can do that. You can go visit with them when they're in your district. You can go to your state legislature. And you can actually easily, if you're in DC, meet with the staff that work with your lawmakers. It's much less involved than people realize. I have been incredibly fortunate. I've had 2 patients to testify for committees at Congress to share their stories. Stories really move our lawmakers. They are very the lawmakers and their assistants take their job very seriously, especially when it comes to healthcare. And when they hear these stories, I've watched them jump into action. It's very meaningful.
Outside of some of the research that's being done already, I'm thinking a lot about the environment and environmental factors because there are a lot of things that we know are harmful in the environment, but we don't actually know necessarily how they impact people long term. I'm thinking about things like forever chemicals. There's a whole host of things that we are yet to really understand their long term impact on various populations and how they impact our genetics down the line. So I'm wondering if there are some areas that you are looking forward to us looking into.
I love that you brought that up. We recently had an ASCO initiative to look at the environment and risk of cancer. And we had a seminar and I learned so much. And then I thought, I can't believe I didn't know some of this. But that information has not been put together very well in the past. So learning about our energy sources and environment with pollution. And one of the things that was really fascinating to me was plastic utensils and drinking from disposable water bottles and all of that. So I think you will see in the oncology space more interest there. Um, there's so much about microplastics in particular that I think we don't understand. The journal articles that came out a few months ago were really just just eye-opening. I was really shocked. I think it was in Nature. And I think we really have so much to learn. To other area where we see this, there's such an increase in GI cancers and colon cancer in young people. We don't really have a grasp on that at all. So it's going to be very fascinating to see where that work comes along in the next few years.
Yeah, I was going to ask you if there are any alarming trends that you've seen. Maybe it's just because I'm chronically online, but I noticed and I'm aware that more young people are getting cancer, and I'm trying to figure out if this is a statistically significant trend or if we're just more aware of it.
Right. Well, and you wonder with improved access to care, improved access to CT scans and all of that, we're going to catch more cases. And then the data is distorted after COVID because you had delayed cancer screening and then you had this huge uptick. So it's so hard to track a population and know, why something is happening. And so there are people who, love to do that work, epidemiology, and look at that. But I think if you were to just, go out in the hall and stop oncologists and ask them, what are you seeing in the hospital or in your clinic that shocks you the most? It would be the young adults with colorectal cancer, GI cancers, because everyone is seeing it and no one understands it.
All right, last question. What do you hope to see in the future?
I would love to be out of a job. I would love for the world to not need oncologists anymore, certainly to not need neuro-oncologists. We're making progress, but when you step back and realize that our Congress is not doing what they said they would do. So they just finalized the 2024 budget a few weeks ago. And how are we supposed to stay ahead of the game if they're not funding NIH, NCI? So a lot of times these people in charge will go out and say they're doing something. And then when you peek behind the curtains, the dollars aren't there. There are so many research proposals that are outstanding that are submitted to the NCI every year that go unfunded because there's not enough money. And so what I encourage people to do is to use your voice, be loud with your voice, and demand that we fund this work.
Wonderful. Thank you so much, Dr. Sumrall. It's been a pleasure.